So good afternoon. I'm very pleased to introduce Dr. Avi Kriechman. Dr. Kriechman is a child and adolescent family and community psychiatrist in the UNM Department of Psychiatry, and he has nearly 40 years of experience providing behavioral health services to children, adolescents, and families in schools, tribal, urban, and rural communities. He has extensive experience in suicide prevention, including creating ASPYR, which is the Alliance Building for Suicide Prevention Youth Resilience, a statewide network in New Mexico. In his characteristically humble manner, he provided a 2-sentence bio for his introduction, and he did not list all his extensive resume, which includes multiple leadership positions in academic medical centers and a large managed care organization, and advanced training and certifications in consult liaison and family therapy. Most of all, he is well regarded throughout our state as a gifted educator. I have personally learned from him over the years, and I'm especially grateful for his focus on a strengths-based perspective that always considers the family, the systems, and the community context. Dr. Avi, we're grateful that you're spending the next hour with us and look forward to learning more about safety assessment and planning. Thank you.
Thanks so much, Carly. It's especially meaningful to me that Carly's introducing me. We've known each other for 20 years already. So welcome everybody. And I'm really grateful for the opportunity to talk about helping people at risk in New Mexico. And what I'm going to talk about today is focusing primarily on safety planning. But before we do that, I'm going to talk about suicide prevention and suicide assessment. And some interesting developments in recent years. And there's a few studies that were just released this week that I'd like to cite too. So for today, I hope that we can talk about what the assess and refer model is for risk management, disposition planning, and suicide prevention. Contrast that with safety planning, including description of its overall structure and purpose, compare and contrast the two, and then look at how to create this stepwise process in coping skills and sources of support, which is what defines safety planning. And then look at why limiting access to lethal means is reviewed towards the end of safety planning, as opposed to an isolation of safety planning or at the beginning. And one of the key things that I wanted to emphasize with all of you is that it's not just the structure of safety planning, it's its implementation. It calls for a special kind of relationship between the provider and the people that we're trying to be of help to. So nothing to disclose. And what I always like to talk about is this optimistic view that suicides are preventable. One of the main reasons that we can prevent suicide, not suicidality, but suicide, is by restricting access to lethal means. For the majority of people, not necessarily the people that a lot of you work with who have severe mental illness with a long history of treatments and hospitalizations, but for the general population, the vast majority of people who are suicidal are in the moment because of some kind of precipitating event and are intensely suicidal for minutes or hours, not for days or day after day or weeks at a time. And so if a highly lethal means like a loaded firearm with ammunition is not available to them, even if they attempt something else, they won't die. And if they have very little available to them, they can, in addiction terms, surf the urge and it subsides, even if they're making an attempt with something that's not lethal. And another part that's so encouraging is people who survive a lethal suicide attempt, less than 8 to 9% go on to make another attempt that's potentially lethal. So the majority of people who make a lethal suicide attempt but survive it, a potentially lethal attempt, do not go on to become chronically suicidal, much less make a fatal and lethal attempt. Early identification and treatment, like it always is, it's the cornerstone of prevention, most helpful. Responsible media reporting relates to that if the media is irresponsible, they don't consult with the family or the community and respect the survivors of someone who suicides, that can lead to further traumatization of all the survivors, including the development of prolonged grief disorder and suicidality within those survivors. But it also adds to the possibility of suicide contagion and suicide clusters. So one of the things that a lot of us who work in public health know is that how the media reports and how the school or the community disseminates information is really important for all concerned. And then the training of all of us. Unfortunately, there's a lot of people within behavioral health who feel that if someone is acutely suicidal, it's not in their bailiwick to help. And they don't feel that they have the tools to do that, and it's not part of their practice. So training people to know how to deal with people who are acutely suicidal and prevent suicidality and prevent suicide is really important. And then alcohol policies relates to, again, means restriction. And follow-up care and community support, I'm sure that all of you know the statistics, which are pretty horrific, is that the greatest chance of people dying is within 1 to 2 months of discharge from the emergency room, inpatient psychiatric hospitalization, even long-term residential treatment. And one of the things that we do, unfortunately, is we may be good at milieu therapy when we hospitalize people or put them in residential treatment, but we don't connect them to their community of support, to their spirituality, to all the facts and the riches and the resources within their own community and their culture. And so they don't have a way of transferring what they may have learned in our settings, in our rarefied settings, in the real world. And I also like to look at, I just mentioned this part, this poll that was done a few years ago that's so enheartening because it contradicts so many myths about suicide. This was in hundreds of thousands of Americans in all aspects of life, with many different backgrounds in many different parts of our country. And that 94% who were polled feel that suicide can't be prevented. There's this myth that everybody feels hopeless about it, that if people attempt suicide, they'll do it over and over again until they kill themselves. Not true. And even more enheartening is that the same 94% said if they knew of someone who was at risk, they would want to help in any way that they could. So there are helpers all out there. These are myths that I wanted to briefly review because they're all barriers to suicide prevention. And unfortunately, a lot of providers share these beliefs as well. If someone is really suicidal, they're going to kill themselves at some point, no matter what you do. It's hopeless. Asking a depressed person about suicide may put the idea in their heads. So many people believe this, and that means that if you have that belief, then you very much avoid having your child or yourself being screened for suicidality, because there's the belief that you never were suicidal before until someone implanted it. And it's actually the opposite. People who do entertain even brief and momentary and transient kinds of experiences of suicidality are relieved that they can talk about it. And especially when you give the statistics like with teenagers, that the majority of teenagers think about suicide intermittently with relative infrequency and not at all severity, with no preparation, action, or plan, but it's a relatively common experience for a lot of teenagers. So normalizing it is helpful. And also looking, this is really key, that suicidality is a way of coping, just like addiction is a way of coping. It's not a good way, it puts you at risk, but it's really important to look at what are they coping with? What are the issues that they're struggling with? There's no point in asking about suicidal thoughts. If someone's going to do it, they won't tell you. Actually, that's a very small group of people. It turns out, and our colleague Jan Fawcett looked into this at great length, is that people who have severe major depressive disorder, chronic, treatment resistant, have been through everything, have tried every treatment with poor response, and they feel sort of legitimately hopeless, that nothing has helped the misery in their mind. And they've learned over time that if they talk about their suicidality, they'll be involuntarily committed, they'll have yet another treatment that won't work. That's their point of view. So they're the ones who don't disclose. But again, the huge majority of people talk about it. And in fact, over-reporting, if we will, suicidality is a protective factor. We'd rather have people talk about it at length as opposed to not talk about it. This results in another discussion that I want to briefly touch upon, which is we want to very much think about how we frame things. So for instance, when we talk about suicide gestures, what we're saying that people who talk about suicide are manipulative or controlling or overly demanding or overly emotional. What we're really not doing is respecting the communication that they're trying to deliver, which is they're suffering in some kind of fashion and they need to be noticed and attended to in a certain kind of way that we need to listen to more carefully. Someone making suicidal threats won't really do it. They're just asking for attention. That's another thing I try to let people know. We're all asking for attention. I'm asking for attention from you right now. You're hoping in our conversation that I'm attending to you. That's what relationship means. So this idea that we're doing something for attention and attention seeking is somehow problematic. We'd, again, much rather have people communicate their distress than keep it secret and harm themselves. If you stop someone from killing themselves one way, they'll find another. Again, all the epidemiological research is the opposite. And so one unusual study is a many decade study of people who jumped Golden Gate Bridge and survived the jump, or someone stopped them from jumping. 95% of those people, so 95% of the people who survive never make a suicide attempt after that. And they'll all say, those 95% who do survive, which is only about 10% of the people who jump, they'll say that within milliseconds, they go, why did I do this? God, I hope I survive. So this idea that people are desperate and will do it over and over again, that's the rarefied few, like in Dr. Fawcett's sample, of the people who have massive and severe and chronic depression with no end in sight. So they're, in their own minds, realistically hopeless about any kind of answer to their suffering. So screening and risk assessment is the traditional way of looking at things. Screening followed by risk assessment. Universal screening means that at every opportunity, youth shows up for a sprained ankle, they get screened just like they get screened for all sorts of other issues. Now, this is hot off the press. The US Preventative Task Force just released recommendations that said that for asymptomatic youth, that there was no provable benefit of universal screening, especially if they're prepubertal children. So it's very important to look at this with a grain of salt. We're also going to talk about the limits of something like the Columbia Suicide Severity Rating Scale soon. Risk assessments are typically done in what's called a categorical predictive model, meaning that the hope is that you stratify people at high, medium, and low risk, and that you can generate a hypothesis about how likely they are to make a suicide attempt within the next few weeks or months. Unfortunately, the research is that that model is unsuccessful in looking at predicting suicidality. We're still, with all of the ways that we look at things, relatively poor at predicting who will make an attempt after we see them and the likelihood of another attempt. But I'm going to briefly allude to another model that, if any of you are interested, I'd be happy to talk about another time. The focus today is on safety planning. So the best practice in the traditional model, that categorical, putting people in categories, high, medium, low risk, and predictive model, is assessing for suicidal ideation, intent, and planning, identifying risk factors. And this is something that I put in myself. This is my child psychiatry hat running, but I think that all of us should really look at what is the context, what is the environment, psychosocial environment, physical environment, community environment that we're looking at, because a lot of us know, especially I think in child and adolescent psychiatry, that when we make a decision about hospitalizing people, it's not just about their individual risk factors and going through their ideation, intent, planning, sort of like the stages of change about pre-contemplation, contemplation, preparation, and action, right? As far as suicidality. But we need to look at who are their guardians, who are their caregivers. If they have neglectful or abusive or disruptive or chaotic environments, somebody at low risk, we might hospitalize in place. Somebody at very high risk with an incredibly supportive and attentive kind of community around them, family, supports, we might consider intensive outpatient, if not even outpatient treatment, because we know that they'll be attended to, that people will support them in their coping and will be preemptive if they feel that somebody is slipping through the cracks. Gathering information from multiple sources is always important. We rarely do that. In fact, a lot of schools will tell you that they'll send somebody to the emergency room, and unfortunately, a lot of schools operate in a very sort of all or nothing kind of phenomenon. Somebody whispers suicidality and they call the police or an ambulance, and not really sort of assess risk along this very huge spectrum. And then when they get assessed, no one feeds back to the school what's going on, and the youth shows up the next day and they have no idea what transpired except that they weren't hospitalized. So screening suicidal thoughts alone are of limited predictive value. And I have a lot of references for all of this at the end, so you can look this up. But what's really important is the issue of access to method independent of current suicidal thinking elevates risk. That's why lethal means counseling and limiting, restricting access to lethal means is so important about preventing death. Important differences exist between those thinking about suicide for the first time versus making a single attempt, those with multiple attempts, etc. And in our assessment, we usually don't take any of that into account. We just look at, in that moment and in the recent past, what was their intent, their planning, their preparation, their actions, their behaviors. We don't look at contextual factors, and we don't look at what's called risk state, meaning that we compare what they are like now to what they were in the past, when they functioned really well, even though they had a lot of stressors and had no suicidality, when they functioned more poorly as far as being at risk. Comparing them to themselves, we also don't compare them to subpopulations. So we don't look at what were other people like who recently immigrated from Ukraine, as far as how they handled things, or people who are transitioning, or people who are worried about being undocumented and transferred from their homes and uprooted from where they are. We don't compare them to other parts of the community that they share to see, are they expressing something that's massively different than anybody else or not? We just look at what's in their head. We don't look about their relationship, their past, their community, their supports, etc. So it's very limited. The other thing is that a lot of people are unwilling to reveal active suicidality for reasons that have nothing to do with that they want to hide their plans. It's because they're worried about confidentiality, especially if they work and they're worried about their insurance company finding out and their boss finding out. They're worried about how things are going to be documented as far as what's going to transpire in the future, the implications of that. They worry about bias. So a lot of people do not report and deny suicidality because of all these other issues, not because they're wishing to not confide in their suicidality for someone that they think is going to help them, but because they're worried about stigma, they're worrying about prejudice, they're worrying about their employment, they're worrying about the implications in their family, and they're worrying about information that they want to disclose to people that they have no idea whether they can trust that person. Screening tools don't capture this moment-to-moment variability. And this is the issue that's really important, is that for the majority of people, the intense desire to kill yourself is very much contextual and precipitated by a recent life event. For adolescents, for instance, more often than not, they have atypical features of major depressive disorder where they are rejection sensitive, very sensitive to criticism, any kind of sense of abandonment. They can be sailing along and seemingly doing very well, and then they're discounted, they're disapproved of, they're rejected, they're abandoned, they're disappointed in someone else. And they think of, in that moment, I just got to escape this. I wish I were dead. And then that abates. And so we're seeing somebody in a moment in time and not looking at, again, how does that compare to other moments in time? How does that compare to times when they did have this kind of interpersonal conflict and they handled it well and they weren't suicidal? And that's a whole other discussion that we'll talk about soon. But we're focused on pathology. We don't focus on potential. We don't look like Carly said earlier, I'm a strength-based person. So our history is all about all the Ds: dysfunction, disorder, disease, diagnosis. And we don't focus on all the times when they could have been overly stressed, when they could have been at risk, and somehow they made a choice not to reduce their harm, to seek safety, to seek security, to find resources within. So our screening tools are limited in all these ways. And I just mentioned some of this. So a study of youth 13 to 34 who attempted suicide showed that for 25%, between the time of the decision to make an attempt and the action, less than 5 minutes. This is not people who ruminate about suicidality hour after hour after hour, and then gradually prepare themselves and rehearse themselves for the attempt. There is a population that does that, but it's a very small group of the general population. Only 14% of suicide attempts were 24 hours after the decision had been made. So the other part of this is that we don't look at self-management. We don't look at coping skills. We don't look at what has worked in the past. We just look at suicidality per se, again, pulling out of all the other aspects of the person. And it's really important because people who have limited self-management capacity are at the greatest risk, but we don't assess it. So here's the Columbia Suicide Severity Rating Scale. I know that a lot of you have received training, so I'm not going to go through this at great length. What we're looking at in this, and this is very important, by the way, this is not a risk management assessment tool. This is a screening tool. Okay? So the screening looks at thoughts, plans, behaviors, and intent, the frequency, the intensity, and duration of suicidal ideas, the plan, timing, location, lethality, is it high lethality, low lethality, availability, any kind of preparation, past attempts. And this is very important to the next part. Is it aborted or self-interrupted, or is it interrupted by outside circumstances? What's really important is it gives you a clue about what parts of that person wanted to have happen. And a lot of times, what seems to be self-interrupted versus interrupted by others is blurred. I'll give you one example. A few years ago, I was actually giving a talk to all the counselors at a school about suicidal risk assessment, suicide prevention, safety planning, etc. And right during that time, a student was found who'd made a suicide attempt at the school. Now, this student had been in counseling off and on, had lots of issues. Everybody was aware that the student was struggling. Where did they make it? The attempt? Not off in the woods someplace or someplace abandoned, in an empty classroom that was only empty during lunch period, heavily trafficked corridor, and they made their suicide attempt minutes before the next class was being held. Now, technically, that would have been interrupted by outside circumstances, but I would argue that was self-interrupted because they timed their attempt to be discovered within minutes. So it's really important to find out all these other factors. And then the intent is the extent to which the patient expects to carry out the plan and believes the plan to be lethal. This is really important too, because we err on both sides. So a lot of times I've had this experience, especially with youth or with even children, is that they have a whole bottle of, let's say, Tylenol, and they only take 4 pills. And then people say, oh, that's a quote gesture. They didn't really intend to die, but they thought that 2 pills were the maximum dose, and if they took 4, they could die. So it's their belief about what's lethal. The other side of it is there's a lot of people who, for instance, they'll take their parents' sleeping pills, and they'll say, well, you know, dad is a lot bigger than me, and he says he needs to take sometimes 2 or 3 to get relief. I'm really miserable. I'm going to take 4. They have no clue that it's lethal, but it's potentially lethal, and they end up in the ICU. They didn't intend to die at all. There was no suicidal intent whatsoever, but they are at risk for dying. And that's another thing that I think that we err on, is we talk about, well, they are technically don't want to die, so they're not suicidal. As opposed to, let's worry about people dying and not have this fine point about, are they technically suicidal or not? So the Columbia screen is there a vague wish to be dead? And one way of phrasing it for children, I participated in modifying this for kids, is, have you not wanted to wake up? And another way to say it is, are things so difficult that you sort of wish you didn't have to face the next day? It's just so awful living from day to day. So a lot of kids, and as my colleagues know, kids 3, 4, 5, 6, they don't have the sense of permanency of death and dying. So it's really important to talk about, is life so onerous, so difficult, so filled with suffering and misery that it's really hard to face the next day? That's sort of on the spectrum of, I wish this suffering would end, I don't know what else to do. And then you have non-specific but active kinds of suicidal thoughts. I've thought about ending my life. I've thought about killing myself. I've thought about maybe what that might look like, or I've heard about somebody else doing that. Active suicidal ideation without any methods is, have you thought about how you would do that, or how you would make yourself not alive anymore? Notice that phrase for children. How would you be in a different kind of place? What did you think about? Okay. So again, they've moved from pre-contemplation to contemplation, but they're not yet there at preparation. Now we're talking about preparation. Some intent to act, without a very specific plan, but when you thought about making yourself not alive or killing yourself, did you think that this was something that you might actually do? So it's not just that you're entertaining this as an idea, but it's something that you're concerned about or thinking about that you might actually go through with that plan. So on some level, you're beginning to prepare for it. And then you are a specific plan, a specific intent. You might know where the guns are and where the ammunitions are. You might know when people are not in the household. You might even rehearse it. So that's preparation before you act. So it's really, if you think of that pre-contemplation, contemplation, preparation, action kind of spectrum, that's really what the Columbia screen is tracing you through. And here's the 6 questions. And this is what I was just talking about that example with the Tylenol and the sleeping pills. Some risky behaviors with no conscious risk to die may result in death. And an example I usually give in community trainings, all true stories, is you have a 4 or 5-year-old little young man who's in a totally chaotic, neglectful environment. Lives near the Big Eye, wanders into traffic. No suicidality whatsoever, highly likely to die because of the level of supervision or the lack of supervision in the home. No conscious risk to die, but it's risky behavior that's being unsupervised. And then some people with a conscious risk to die, it may not result in death because they chose the wrong method, something that's unlikely to end in their death. We have to assess that too. So it's important to determine the relative risk of both kinds of aspects. And you can see how that loops back to what's the context, what's the environment, what's the supervision, who are the caregivers, what are the guardians, what are the community supports. So I'm going to quickly go through this as far as that there is a more advanced risk assessment version of the Columbia, which is not just the suicidal and self-injurious behavior and the suicidal ideation, but activating events, like I talked about. A lot of times it's interpersonal conflict or lack of support, treatment history, other risk factors, recent losses, clinical status, protective factors. And then you can see embedded in the end is the Columbia screen, actual and potential lethality of method, right? So this is a more extensive model, but it's still the categorical stratified model that tries to be predictive, which again has little evidence of efficacy. So risk factors, I don't think I need to belabor. It's what we're steeped in, but we don't talk a lot about this, which is that risk factors can vary by age group, culture, sex, and other characteristics. What's really important is that for under-resourced, stigmatized, discounted, disenfranchised communities, if we look at all those social factors and cultural factors in the larger culture, the dominant culture, which oppresses people, denies them access, stigmatizes them, that if we separate that out for people who have access to those resources, who are supported in who they are, who are given the same resources as the dominant culture, they have the exact same risk factors as everybody else. So these risk factors are not intrapersonal, they're social. Internal protective factors, and again, we focus in our assessment almost solely on risk factors, and we view protective factors as sort of like the opposite. What we do in safety planning is look for reasons for living and diminishing reasons for dying. We focus on all the richness of the resources and the competencies and capacities and the talents and the skills and the strengths and the supports and the unique understandings, the value, the meaning and the purpose and the ideals that that person all brings with them. That's what we selectively attend to build reasons for living. Hope for the future, attachment to life, sense of belonging, confidence in their ability to solve problems and focus stress. The way that we define crisis is some kind of event that challenges our current coping skills. Rather than having the belief that people are deficits, that they have nothing, we always look to, in a solution-focused kind of way, the time when they had a similar challenge, but met it differently, better, but preserved their well-being, their sense of themselves. So we selectively attend to all the times when they reduced their harm, all the times when they handled a very difficult situation to the best of their ability and had some kind of success. So we're looking for all the things that we can build a foundation around that's within them and their capacity. We have confidence in their desire for recovery. Recovery is a need, not a want. It's a basic need, just like food, clothing, and shelter. Good frustration tolerance, really helpful. A protective factor is being afraid of suicide, including the idea that you'll make an attempt and instead of dying, you'll end up paralyzed, you'll end up on a heart-lung machine, you'll end up a quote vegetable, you'll end up in a way that's a burden to everyone around you. Fear of the social stigma and fear of disapproval of suicide, that is a protective factor. Belief that suicide is immoral. And again, like I alluded to earlier, if you're motivated to over-report, right, that's much better because it's much better that you cry for help and hopefully someone wise attends to you than you keep it all a secret. External protective factors are, you have responsibility. I'm sure a lot of you said when you've talked to other people who've been suicidal, that they've said to you that, you know, who's going to take care of my dog? Who's going to care for my baby? I can't do that to them. For myself, I feel like there's no possibility, but I have responsibility for something that's living, for something that's important to me. Social connection. And we discount a lot of our social connections. A lot of people will say they have no one that supports them, but they bump into the same people when they walk their dog or take a hike. They have somebody who in the grocery store who packs their groceries for them, that if they weren't there, they would feel a loss. There's all sorts of people that we take for granted who support us, who nurture us in small but very important ways. And a key part of this too, a protective factor, is the availability of suicidality-specific effective care. And 3 of the models that have been evidence-based for youth as well as for adults is the collaborative assessment and management of suicidality from David Jobs, which is an offshoot of dialectical behavioral therapy, which is also highly evidence-based. And there's a forum of CBT for suicide prevention, CBT-SP. Those are the 3 evidence-based treatments. And I understand that most of the providers in New Mexico are not trained in any of these modalities. It's very important that we expand access to treatment, but especially access to treatment that has a track record and evidence base of reducing suicidality and suicide attempts. Limited access to lethal means, like I said, we're not great at preventing suicidality in that moment, but we're really successful in preventing death, preventing suicide. And then cultural and religious beliefs that discourage suicide. In DBT and then in CAMS, those 2 models, we have reasons for living inventories. And these are just a list of all the possibilities to generate brainstorming in people about what speaks to them for reasons for living. And I just listed a few on these slides. Emphasizing again, this is for me about really looking at the quality of supervision, monitoring, and caretaking in their household. And that applies for adults too. Support for reducing access to lethal means. That's really important. And again, we're talking not about gun control, we're talking about safety. And most people really care for the people. They would be terrified and horrified if their young child thought it was a toy and killed themselves. They can understand the importance of firearm safety. Support for the treatment, support for community outreach, not feeling so worried about what other people would think and about social stigma that they want to take care of that person. So the standard idea is stratifying risk level to high, moderate, and low. They're very transparent, so I'm not going to belabor that. The problems with this, what's called the assess and refer model, is that this can be disconcerting to people and family because they experience the formal risk assessment and management as disempowering. It's all, the expert is asking you questions, and the assessment is often not a conversation, not a collaboration with the person or their supports or their family. It's like, I think you need X, Y, and Z. It's not patient-centered. There's not shared decision-making. So that's one of the reasons why it's not helpful. Another reason is because many suicidal individuals don't follow up. Like I mentioned, the highest risk of suicide is after discharge from the emergency room, after discharge from the hospital. And a lot of our referrals are not all that helpful. Sometimes I understand from a lot of the people out in the community that there's no one who will accept somebody who's acutely suicidal. Or they refer to somebody or an agency that has like a 3 to 6 month wait list for somebody who's just discharged from the hospital. Or they refer to some kind of person or agency or provider that is not at all a fit for the person who is in need. So it's not a surprise that the vast majority of people do not follow up even for one visit. And also, a lot of times in emergency rooms, it's basically the message that families and individuals often receive is, you don't need to be in the hospital. I'm not going to send you. Here's a number to call of a hotline, or here's a number to call of a clinic, as opposed to calling the clinic, see if they have someone that you can make an appointment with. Case management. Case management is often lacking. So again, overall, the statistics are up to 60% of suicide attempters attend only 1 week of post-treatment. The vast majority don't even attend. And of those people who attend 1 week, right, then there's a smaller amount who go for a couple of months and then they drop out. So follow-up is really poor. Oftentimes, it's because we have limited access and limited resources, but it's also that we're not thoughtful in case management. So what I've been talking about is what's called the prediction model. This way of formulating risk has predominated in psychiatric education and practice, despite little evidence for its validity, reliability, or utility. And I have a lot of references in that regard. So an alternative model is what is called the prevention model, looking at risk status, their risk relative to a specified subpopulation, risk state, all of these I mentioned earlier, looking at different points in time of how they manage things, available resources that they can draw on, and foreseeable changes. If they have recurrent events or stressors which provoke things, now I'm going to go into safety planning, and I'm going to cover this relatively briefly, but there's a lot of information. But what I wanted to emphasize in all this assessment is that this assessment is not a good guide to safety planning. It's not a good lead-in. So it's really important that we do this kind of preventative assessment that is addressing the whole person, looking at strengths and assets and competencies, looking at shared decision-making, viewing ourselves as scaffolds as opposed to foundations for people, emphasizing reasons for living. They are the experts who teach us. We are there to mentor, coach, support, and scaffold, not to direct, not to prescribe, not to be the experts on themselves, and to treat the whole human being, looking at potential, not pathology. So this is the way in which Stanley and Brown looked at collaborative, co-created kinds of ways of safety planning. And the 7 steps are warning signs of an impending crisis, not when the crisis is right at hand, but impending. And an easy way for all of us with our medical backgrounds to talk about this is it's the same thing as you teach diabetics, what does hypoglycemia or hypoglycemia or ketoacidosis look like for you? When should you check your sugars? When should you go back to your endocrinologist or your PCP to look at your insulin management? If you're an asthmatic, when do you use your breakthrough medicines? When do you use your inhalers? When do you need to go to urgent care? If you have someone with migraines, what does an aura look like? When do you know that you might need an injection as opposed to a pill? So the idea is, what's the warning sign where you trigger your plan? Same thing in safety planning. And that's totally idiosyncratic for different people. It could be, I'm really cranky and irritable in my relationships, and normally I'm easygoing, or I'm too sensitive, or I'm not sleeping well, or I'm not taking good care of myself, or I feel like I want to isolate from everybody else. It's different for everybody, but it's not when they're in full-blown crisis. It's when the crisis is impending. And that's when they say, time to initiate my plan. And we start with, on my own, what you can do, what's within your own capacity. Because what we want to say is, you have the wisdom and the experience and the resources to cope. Let's look at what comes naturally to you. Here's a lot of ideas. In Seeking Safety, which a lot of you know that I teach, there's over 80 coping skills that we start with, safe coping skills, and we add to that as we go along. So again, we're looking at potential and possibility. One sort of solution-focused way of saying it is, what good coping have you done? So we're saying that you do good coping at least some of the time, and you've done it in the past. That's again a strength-based, solution-focused kind of way of looking at coping strategies. Then we look at with a friend. So you're not connecting to other people because you're looking for guidance or counsel or wisdom or experience, or even tangible, pragmatic kind of support. You're looking to others for connection, for distraction, for taking yourself out of that ruminative, difficult, traumatizing kind of place to some kind of neutral space. Let's just take a hike. Let's just meet for coffee and let's watch a movie together. Let's go dancing. Let's go singing. Let's see a movie on Netflix in a group kind of way, or play video games, whatever it might be, to connect outside of yourself and detach yourself from that kind of emotional pain. Ground and center yourself with other people. Then you might look at a tele-friend, that's what it's called, when you're looking to say, you know, I'm feeling really down. I sometimes even thought about hurting myself. Here's the situation that I'm dealing with. Do you have any advice for me? Or I think I might need to go back to the emergency room. Would you be able to sit in the waiting room with me so I can just talk with you about it? I'm not looking for anything more than that, but I would really appreciate your support. If what they do on their own or with others in their natural support system doesn't meet the challenge for that precipitating event, then we ask them to contact all of us, and warm lines and text lines and hotlines and drop-in centers and crisis centers and everything that might be available to people. So we start with, what do they sense when they're about to be in trouble and they're more vulnerable and they're more vulnerable to risk for self-harm, what they can do on their own, what they can do with others in a neutral, connecting, distracting kind of way, what they can do with others to provide advice and counsel and wisdom, and then look at us. And again, in our assess and refer, oftentimes what we do is, here's a suicide hotline, here's a professional. We don't investigate any of the rest of this. After we've done all this, that's when we talk about limiting access to lethal means. And why we do that is, as opposed to the start, and there's a lot of research that if all you do is lethal means access counseling, it's effective, but not nearly as effective as when it's embedded in the rest of safety planning. Why? Because we started with saying, you know yourself best. Here are all the warning signs that you're about to have more difficulty if a challenging kind of thing happens to you. And then here's all the supports that are out there. Even ones that you may discount. You bump into the same person when you walk your dog in the same park. Say hello next time. Have your dogs walk together. They always get along. You look forward to that opportunity and it pulls you out of that isolated, ruminative, difficult kind of place. And then look at all the wealth of resources, including case management kinds of things like supported housing, supported employment, dealing with food insecurity, food banks. They're all out there. Now that you have all these resources, like we know, for you and for a lot of people, that impulse to kill yourself was very brief and very transient because of something that happened in a relationship or in your external environment. Something happened that provoked it. So on that odd chance, wouldn't it be great, since you've shown me in what you've talked about, that you really want to move towards other people, towards healing, towards harm reduction? Wouldn't it be great if you didn't have a loaded gun? Because unfortunately, if you use that gun, 90 to 95% of the time, you die. You wouldn't survive. By the way, if you overdose, less than 2% kill themselves through overdose, less than 1% through cutting. So if we look at a loaded gun, and then most people, we've generated hope. We've generated and supported reasons for living. So they're much more wanting to, in that moment, do something about restricting lethal means. Hopefully that all makes sense. And then what we do, this is more what I talked about that strength-based collaboration. And it lists all the ways in which you have to implement it to be successful. And the outcomes are sort of stunning. In some studies, when it's done in an emergency room in this kind of 7-step way, embedding lethal means access towards the end and ending up with discussing the likelihood of them using the plan, what motivates them, reconfiguring the plan so it meets their needs, and ending up supporting reasons for living, that one 20 to 30 minutes safety plan session can reduce suicidality for the next 6 months. That's stunning. And that follow-up rate increases 300%. So safety planning, when done well, is highly effective at reducing death. So here's again the plan. Warning signs, what are some of those early and initial thoughts? What are some distraction techniques that I can do by myself on my own coping? Who can I call to help distract me? Who can I call for help? Professional, keeping the environment safe, and what is the most important thing I need to remember about why I should live? The one thing that is most important to me and worth living for is, so we're building our case for reasons for living. And in this collaborative, co-created, shared, transparent, strength-based, potential-seeking kind of model, we're generating hope. We're also being an ally for harm reduction as opposed to exposure to harm and risk. So here's more details about all of that you'll see in the PDF that Lillian has posted for you, and she'll send it to you by email again. And what I always want to say at the end of this is, I have information, by the way, about specific techniques about looking at lethal means counseling. You can look at motivational interviewing and solution focused to support reasons for living, like I've alluded to. The one thing that is most important to me and worth living for is reasons to live are coping strategies. Reasons to live reduce suicidality. And recovery, that's the way I always like to end, is not the absence or the reduction of symptoms and signs and suffering. Recovery is reconnecting to meaning and purpose in life, restoring the ideals that you thought you'd lost, having a future way of looking at yourself, which has compassion for yourself and compassion for others. I put my email in the chat so we can continue this conversation. Feel free to either put a question in the chat, or if you have any questions you'd like to unmute yourself, whatever. Thanks so much for giving me this opportunity to speak with you.
Thank you. I have a question, and it's so often now we're doing team-based care where one person's doing the screening, somebody else might be doing the safety planning, somebody else might be doing the follow-up afterwards. And when you're doing the safety planning, what are your thoughts about how to best communicate that across this sort of across this chain of a team?
Yeah, that's a wonderful question, Carly. Thanks for prompting that. Because I think that's another way in which our system sort of silos off different aspects of a person. And you've been through this spiel with me before, that every time we meet somebody, it's a therapeutic intervention. But we make this decision between, and division between triage and screening and assessment and referral and crisis intervention and treatment, et cetera. So I think the ideal way, right, is that the same person does everything, right? But if not, I think what would be really helpful is, like we talk about, in ASPYR and other settings, the warm handoff. So it's like, well, let's say that you were doing the screening and I was doing the safety planning, that you say, my partner in crime here, Avi, is going to be talking about safety planning to continue our discussion. And he's going to focus on all the ways that you can cope when you do have these kinds of thoughts and feelings. So just a little bit of, a prologue, so that we're connecting it to make it feel like it's all seamless, that they're all interconnected. And hopefully it actually is.
Yeah. Thank you, Avi. This is Juan. Thank you for this great presentation. And for me, I'd like for you to comment. One of the things that I see still in PS call is clinicians, some more experienced than others, sometimes feeling comfortable making suicidal assessments in 15 or 30 minutes of a person that they've never met.
Yes.
And hearing, your great, comprehensive synthesis and holistic view. I mean, to me, it's always seemed, just incredible that no matter how experienced a clinician could make this most difficult decision with someone who they've never met in that kind of time. Especially when it's done through video. I think we are sort of enamored now with the video, but how you miss so much of the in the room interaction and the actual therapeutic relationship that you can build, that you need to build in order to fully assess someone in this most critical of psychiatric settings. That it just seems to me that we're going backwards when we think, oh yeah, no, it can be siloed, the assessment can be siloed, and of course some of it can be done on video. And I just wondering what your thoughts are on this.
Well, you're preaching to the choir, as you suspected. I also have to take the opportunity to say that Dr. Bustillo is one of the most humane, kind, holistic psychiatrists you could ever imagine. I know his patients really treasure their moments with you, because you do see the whole person. But I think you're totally right. And I think it's this binary and overly reductionist decision, right? It's like, are you suicidal to the extent that you need to be hospitalized or not? And that's all that people sort of focus on, right? And they don't focus on all the other aspects of this, which are so critical. And it's too reductionistic of a view. And like we talked about, that doesn't really mitigate against risk, because it's not the people who are hospitalized or not, it's the people who are hospitalized and then left with nothing, right? And they have this idea, and we're also reductionistic about when we say you're stabilized with suicidality, as if that happens in a day or two, right? So I think what you're saying is this is a conversation between two people, and that the whole idea of feeling so miserable, having such mental suffering, that you feel that the only way to act is to end your life, is something that we can't reduce to 15 or 20 minutes of a structured interview. It's an existential question, and we really have to connect in a truly deeply meaningful way to people. And again, looking at that whole person, and again, focusing, not solution forced, right? But really looking at balancing our view of potential with pathology, and looking at things contextually, in relationship, in community, all those other factors other than our typical focus on what's intrapsychic as opposed to what's interpersonal, what's communal. So I couldn't agree with you more. Anyone else has a question? Or something that they'd like to bring up? One thing I did want to alert you, that a lot of you know this, but I've done a lot of teaching of seeking safety over the past decade or so, and instituted that in one of the 5-year ASPYR programs, and a lot of Dr. Casanti's work with structurally homeless people who also have severe mental illness and addiction. And it's been very helpful. Well, seeking safety, 80 to 90% of it is safety planning. And it had on a lot of the topics and a lot of the handouts and a lot of the techniques embellish and support safety planning. And it goes into a lot what Juan was saying, which is it addresses all aspects of the person and realizes that recovery, again, calls on all different aspects of themselves. And it's not just symptom reduction. And the decision to hospitalize is one with great weight and great import. And so it's really important that, using DBT terms, we use our wise mind as opposed to either our rational mind or our emotional mind to really connect in a humane, holistic kind of fashion with others.
Thank you very, very much, Avi. We really just appreciate your thoughtfulness and your talk today.
Thanks so much, Carly. Feel free to contact me. Good to see you all. Be safe.
Bye-bye.